போதான் லைவ் செக் பண்ணுறோம்.
Alright, so we'll just continue with whatever has been discussed earlier. So I'm just going to emphasize the same content or the concept, but probably in a different direction. So, heuristics and bias in clinical decision making. So, bias is mostly known word for everyone. So, bias is like when we deviate from any rational thinking, when we take a shortcut to decide something, then we call that as a bias. Heuristics, again, it's a type of mental shortcut, okay, or what we generally call heuristics in a more colloquial term is rule of thumb. Okay, so we all know what is rule of thumb, right? Rule of thumb. What is rule of thumb? Rule of thumb. Seriously.
First basic rule.
First,
Basic rule are unique.
okay, like if you don't know, or if you don't know in a more evident manner, okay, so we select or we take the course of action based on our experience or past experience. Okay, so that's called general rule of thumb. Or whenever we don't know the proper way of approaching it, then we have a most acceptable route to attend that particular problem. It's called rule of thumb. Okay, so what is the common use of heuristics? Okay, generally when we take a decision, we take in a broadly in a two way. Okay, that's what Daniel Kahneman. Yes.
What is heuristic?
Heuristic is a mental shortcut. That's a rule of thumb. Shortcut. That's what I'm trying to explain. So when we take a decision, we take decision in two ways. Okay. So one thing is, say for example, if you are driving, okay, and you have a person approaching you from the right side in a more over-speed manner, okay, and you think that he is going to cut you. What is your immediate response? You slow down, yeah. So because you think he might come and hit you. So did you think anything else? Like did you analyze what is the speed of the person, in what speed you are driving, or what lane he is coming, whether he follows the lane discipline, or is there any other things which you consider? Yeah, you didn't consider what speed you are driving or what speed is coming. Probably you just think he's overspeeding. That's all. That's the only thing comes to your mind. So that is a kind of intuitive thinking. Yeah, and there is another kind of thinking where we take more of analytical thinking. Okay, say for example, when you go into a say for what we call passport like when you put a drop of coin, it will pick up things for you. Yeah. Now when you do that, you try to move it more analytically. Yeah. Okay. You think, okay, that is the most. Which part of that field has most product inside, or which part of field has most graspable area? Okay. So you try to think. You try to analyze the situation and then you try to move it. Yeah. So that's the way we think. Sometimes we analyze the factors or variables before we take a decision. Okay. So these are the two common way of thinking. Okay. Now what happens is, as we do things again and again, our analytical thinking moves more to the intuitive thinking. You agree? Yeah, when we do that same thing again and again, initially we analyze things, okay, so maybe it will be the judgments or the course of action is very slow. But when you start doing that again and again, it tries to Okay, when we do the same course of action again and again, then at one point of time, you don't think about it. Say, for example, in cricket. Yeah, how many of you play cricket? Yes. Okay, when we start playing cricket, we initially take a lot of precaution in taking guard, in taking forward leap and things like that. But once you start playing the same ball, okay, again and again, the shot comes intuitively to you. Yeah, you no longer think about what guard you are, okay, whether you are taking a forward leap, whether you are bending your head, whether your hand is straight, nothing comes to your mind. You don't analyze it anymore. But when you start playing cricket, you analyze all these things, whether your hand is elbow straight, head is down, okay. So this is the kind of thinking which happens for everyone. So it is based on the experience who is taking what kind of decision in what course of time. Everyone agree? So not everyone can lead to that decision as simple as that. Okay, it's because the experience and the work nature may be different for two different reasons. Okay, so this is what Daniel Kahneman said. Two way of thinking: one is intuitive, one is analytical. Okay, and now why does it matter to us here in healthcare system? Okay, why does it matter? Many times when we say, for example, in emergency room, patients are rushed into the emergency ER room. Okay, now do you think is there sufficient time to analyze so many things in the context? Very less time. Yeah, probably every second is very valuable time. Okay. Now, if I say that you have to be more analytical here, okay, then probably you can lose the life. Okay. So we need to be more intuitive here. Okay. Again, the intuitive comes because when the physician is more experienced, his intuition will be more accurate than the junior physician. Yes or no? But still here the decisions are very rapid. Yes or no? And to we know that what are the advantage of doing this mental shortcut is it reduces the mental effort to make decisions, and sometimes in a very complex situation it helps us to simplify the situation, and they are fast. Of course, we know that because we arrive at decision very sooner. They are mostly what they have found. It seems to be accurate in most of the conditions, not every time, but accurate most of the time. Now, so this is one example of heuristic. Yeah, algorithm. We see algorithm in healthcare system many times. Yes or no? All our guidelines. Yeah. Be it for diagnosis or be it for treatment, we have this algorithm. Yes or no? You may also have
Previous.
previous. You may have, okay.
Yeah. Video.
Okay. You may also have seen this. Okay. Sorry, the font size low. This is the algorithm for ACLS, advanced cardiac arrest. Okay. Now what it says is start CPR. Then if the rhythm is shockable, go for defibrillation. If it's not, then again you have all these things to consider. Yeah. Now what does this algorithm gives us? It gives us a cognitive aid, a tool. Yeah, for us to take the course of action in a very rapid way. Yes or no? If this cognitive tool is not there, probably to give a treatment, okay, the treatment selection of treatment may vary from one person to another. Yes or no? So one physician may have a particular inclination toward a treatment than the other person. So there is a lot of things which influence the physician to take a particular intervention. So this cognitive tool helps us to be a more standardized way of approaching a patient, which is also very fast and which is also seems to be very accurate. Yeah. Now we tend to ignore a lot of information here. Yes or no? We just see whether the rhythm is shockable or not. Okay, we ignore all the other information. We just look into one factor whether the rhythm is shockable or not. We ignore other informations or the other vital signs. Okay, what is the heart rate, what is the respiratory rate, we tend to ignore all the things. But still, looking into one factor and you taking the course of action based on that one factor seems to produce better results. So, having said that, okay, it helps us in certain situations when we don't have sufficient time, when the decision has to be made more rapid way. But what's happening in reality, it is also reflected in many other systems of healthcare. Okay, sometimes it is even abused in a way where it is more harmful than the benefit. Now, the question is, when is a door not a door? Okay, anyone have an answer? Okay, anyway, I'm not going to say that. Okay, now this is a picture. What do you see? Is there anything you can make up from the picture or just dots and whites? Anything? Like, does it make anything? Yes? Dog. Okay? So, dog is the after. Okay, so not for everyone can appreciate dog. If you haven't seen the dog, it's okay. Okay. Right. So I'll explain you what that picture tells us. Okay. Now this is a question: how often we prescribe incentive spirometry for abdominal surgery patients? Everyone? Mostly everyone? You or none?
Everyone.
How many of you say everyone? Okay. Mostly? Mostly? Few? Okay, then I suppose you're not working with abdominal surgery patients. Okay. Anyway, at least what do you think? Even if you're not seeing patients, that's okay. What would be your preference in for abdominal surgery patients? Will you prescribe incentive spirometer for everyone? Few? None? Anyone say none? Right. Okay. Now, but if we ask or if we go and see what's happening in the real setup, okay, it's being prescribed right and left to every patient. Yeah, the incentive parameter is just whenever the patient is posted for any surgery, it's being prescribed incentive parameter. Okay, that's what's happening. You may have a different opinion, but in many places, this is what's happening. Okay. Now, we have sufficient information to contradict this practice. This is a RCT published in a Lancet where they have found out that it is not making any significant change in terms of outcome. Okay, and particularly in a resource constrained environment. So they have done this study in a resource constrained environment. And what they have found does not result in statistically significant. Means it is not sufficient to say whether it is actually beneficial to patients when we prescribe for everyone. Okay, but still it is common practice for everyone to prescribe incentive spirometer because how do you decide to give incentive spirometer for abdominal? What made you decide to give that? What made you decide to give or prescribe spirometer for patients?
Maybe you would have studied it earlier.
Pre-existing beliefs.
Maybe.
You would have studied it earlier.
Okay. Any
Because
other?
they want them to go harder.
was harder.
Pre-existing belief. So ಊದನ ಸರಿಯಾಗಿ ನಾವು.
All right, pre-existing belief.
Because
They
of pain.
have physiological rationale for
Right. So when we breathe and when they have feedback, they get better. Okay.
You may think because of pain they don't feel.
Okay. Then you could just ask them to do a deep breathing exercise.
you want them to have a feedback of
Feedback. Okay. So that's all. Is that the reason? Right. So we have some reason or other for us to decide why we are giving incentives by route. Yes or no? Okay. Let's come to those why we are giving later. Okay, we'll move to the next question.
Next.
So again, this is another study which is published in Cochrane systematically saying low quality evidence for lack of effectiveness of incentive spirometry for post-operative pulmonary complications. Okay, both are published in a highly reputed index websites like Cochrane and the other one is Lancet. So we can rely on that. Okay, how often we deliver chest physiotherapy for pneumonia in adults? Like chest physiotherapy, you have to define, sir.
mostly everyone.
Mostly everyone. Okay, everyone agree? Chest physiotherapy means we do chest clapping, percussion, vibration, yeah, all those things. Now again, this is another Cochrane database systematic review. Chest physiotherapy for pneumonia adults. Okay, this is the conclusion. Might not be recommended as a routine recommended or a treatment for pneumonia adults. Okay, the treatment we give right and left for all the patient ICU, and what actually information or evidence is looking at us telling it might not be recommended as a routine treatment for everyone with pneumonia. Right, but still, what made you to give chest physiotherapy for all patients for with pneumonia?
Because it makes sense.
That makes sense physiologically. Okay. Anything else? Anything else? Why do you want to chest physiotherapy for pneumonia? Other than physiological rationale? Any other reason why you decide to give chest physiotherapy?
Okay. You're being prescribed something.
Right. That's what I'm expecting this to say. Right. Okay. How often we prescribe electrical stimulation for the everyone?
எழுதி கொடுத்தாங்க வச்சா.
This is again systematic review from Cochrane. Okay, physical therapy for breast palsy, and if you can see, no high quality evidence to support benefit or harm for any physiotherapy. Okay, so which includes stimulation within. Okay, and they have to have some low quality evidence for facial exercise, probably because sir, your study. So the evidence is looking at us telling it is not beneficial, but still we choose electrical stimulation for all the patients with breast cancer. What made you to select? Huh? Brilliant. It's being said, okay, said by those. Anything else? Why you selected stimulation as a
Other than selected being prescribed.
it is being described, okay?
Habitual. Next time.
Okay. Okay. Now we have seen certain situations where we select a treatment as our choice for some reason. Okay. And when the actual literature or evidence is saying or contradict our belief, okay. Now why this happens? People have different reasons. Yeah. Some say it makes sense because the physiology of chest physiotherapy is you do percussion and there's some vibration going inside and it helps to create secretion, things like that. and some said it's being prescribed, some said it's being given in the books. Yeah, but if we try to think why these kind of decisions are being made, okay, added with your answers, I think we have even more answers. Maybe if I say, you will think, yes, that is also one of the reasons why you have selected that. Okay, so yes, many times I think it's been discussed earlier. I will just try to emphasize again. So when we try to prefer action over inaction, yes or no? How many of you seen penalty kick in the football? Penalty kick in the football. Penalty kick. Okay. How many of you? How many times you have noticed goalkeeper jumping to either side, right or left? How many times? Almost every time. Okay. But what they have found, if you just stood there, you would have blocked many penalties rather than jumping to right or left. Okay. Just a very crude example, but just to make you understand. Okay. Sometimes inaction is the best course of decision rather than action. How do we come to the point we have to analyze what is or which one is more benefit and which is having harm? So if taking action is more harmful than taking being inaction, then I think we have to shift to being inactive or not doing anything. Okay, so that is what I think in Bell's palsy we have to do, because we know that Bell's palsy is a disease with a spontaneous recovery. Yeah, we also, it's a neuropraxic condition. We know that in 3 to 4 weeks of time it does recover. Yeah. So all we have to do is just reassure the patient, and with some amount of activity which involve facial muscles, I think we have to send them home. Yeah, and we try to do something because the patient also validates that doing something for them helps them getting better. Yes or no? Sometimes patient comes to a physician, okay, and doctor just writes something. He thinks he's not being attended properly. His concerns are not validated properly. Yes or no? So when the doctor writes X-ray, the patient feels happy suddenly. Yeah, when more tests has been written or prescribed, the patient feels happy because the patient thinks, okay, his worries or concerns are validated by the physician. That's why he's writing more tests. Yeah, so it may have some value from patient's perspective, okay, but when you prescribe the X-ray, okay, what is the harm effect of this kind of X-ray? Probably more radiation, because we know that chest X-ray or any other X-ray, the patient is exposed to more radiation. Or if it's any invasive investigation, what is the risk of doing that investigation? Okay, so again, the cost aspect of the investigation. Okay, because when you see the bigger picture, the government doesn't want to spend unnecessarily on the investigation which doesn't lead to any outcome. Yes or no? So we need to sometimes just ask the patient to reassure and follow them up for any further progression. Say if the symptom is worsening, we can ask them to come back later. Okay, rather than prescribing investigations right and left at one single visit. Yeah, and so the other reasons why we select a particular course of treatment is, say for example, if I ask you if you have flu-like symptom, okay, probably with respiratory symptoms like sinus cough, okay, and myalgia. Today, what is the immediate reaction? What do you think you have? Corona. Yeah. If I asked you the same question 1 year back, what could be your answer? What would be your answer? Simple flu. Okay. So today you may have even a simple flu. Yeah. But everyone immediately jumps to the conclusion of COVID. Yeah. Because that is what is available everywhere. Yeah, you go and see the street, Corona. You open the news, COVID. Yeah. So wherever you see, it is filling up the mind. Yeah. So this is a simple example of what is availability bias is when you are filled with a particular information again and again. Okay, then that's what comes to our mind. It may be true, but not all the time. Yeah, so sometimes you have to step back and see or step back and decide whether it is the recent information which is influencing your decision or it is actually you gathered some information to come to that particular decision. Okay, the other reason why we decide the way we decide is, say for example, 15 or 20 of us here are saying, I will give electrical stimulation for Bell's palsy. Okay, and one person alone is sitting with a difference of opinion. Okay, we all say that we should give electrical stimulation for Bell's palsy, and the person, one person sitting, is having difference of opinion. But what do you think will be his choice now in this room at this point of time?
Yeah.
Whether he will opine his difference of opinion or he will go with the other 90. Many times we go with what other 90. Yeah, so that's called bandwagon effect because you don't want to stand out. Yeah, we want to fit into the group. Yeah, that's called bandwagon effect. So when a group of people thinks that is true, then we also think or we also wants to be in the group, so okay, that is true. Yeah, in a simple way, when Tamil சொல்லுவாங்க வெள்ளக்காரங்க பறக்குது அப்படின்னா பறகு சொல்லியாங்க இல்லாட்டி ஒதுக்கி வச்சிருவாங்க. Yeah, so you don't want to be that. So the bandwagon effect is you think in a group and you don't want to stand out. Okay, so the other important error we make when we take a decision is many times we have some information like what we discussed earlier. We all have knowledge which is taken from here. Yeah, so we all studied something. We it's not like we didn't analyze anything. Yeah, we all analyze something. We all have certain beliefs for what we read. But when we take a decision, okay, what we generally do is you confirm or you take a decision which fits your belief. Yes, sir. If I believe that dry needling is helpful, okay, dry needling is helpful because I assume there is a physiology of tight band. Okay, there is physiology of ischemia happening. Okay, then I somehow convince myself, okay, it makes sense for me. So now, what do? I select dry needling as a choice of treatment for muscle pain. Yeah, because what I do is I take information like, okay, I palpate. Now I could sense some tight band. Okay, so there is a trigger point. Now because this confirms my preconceived belief that okay, that trigger point are painful or trigger point are problematic, they produce pain. So now I select a treatment because that particular information of palpating a tight band confirmed my belief that this patient is having a treatment. Yes, sir. So we tend to gather information which confirms our pre-existing knowledge. Now, this is another important way of taking a decision. Okay, sometimes the patient comes to us with a prescription. Yeah, mostly written by orthopedician. What is the usual prescription for any problem from the orthopedician? IFD for
low back pain.
Low back pain. Now it's already entered our mind. It's a low back pain. Yeah. So you go on do some rituals which confirms or which is revolving around the diagnosis of low back pain. Yeah, maybe a reflect pain from organ. Yeah, he could have missed. Yes or no? It may be a red flag, okay, it may be tuberculosis or pot spine, maybe anything, okay. Because we know that sometimes the red flags are also missed from orthopedician and comes to us, and from our diagnosis we think it's red flag and we send them back. Yeah, but when you read the prescriptions in low back pain, you do some assessment or some tests and measures to confirm your diagnosis of low back pain. Yeah, of course, we also do other things to rule out, but it's already in your mind that the patient is having a simple low back pain. Yeah, so when you have an already established diagnosis, we anchor our belief around that diagnosis, and we tend to collect information only around that diagnosis. Right? Okay, this is, I think we all agree, Maslow's hammer. Okay, so anyone know what Maslow's hammer?
Have a hammer, everything in the name.
Yes. So if I give you hammer, what do you search for?
Nail.
Everyone search for nail. Yeah. You just want to hit everything with the hammer and you find the nail. Okay. Now, why is this important is, say for example, recently you have attended a beautiful course of okay.
Tapping.
Taping.
Taping.
Okay. Taping. Okay, you have attended a course on kinesiotherapy. Now you come to the clinic. Okay. Now a patient comes to us, comes to you. He's saying a pain of tennis elbow. Okay. Now what is the first line of treatment? First line of treatment is taping. Another patient comes to you. Okay. Low back pain. What is your first line of treatment? Taping. Yeah. Why?
Because I have a hammer.
Yes, yeah, because you think you have a tool now which works for every patient and for every condition, so you go search for the nail. Okay, so the hammer is taping, the nail is the connection. So you just go hit the tape with all the conditions that can exist in the world. Can cure just anything, cancer, say what not, can you think we can cure? Okay. So, right, so there are, and our way of cognitive error not just stops with what we discussed. There are n number of ways we can go wrong. Okay. But these are these are some of the common reasons how we go wrong. Okay. The social influence of okay, because that's been prescribed and that's what been practiced by many of the senior therapists and that's what I've been said to do. Okay. How to overcome this? Yeah, because we know that this is not good. This is going to harm the patient. Okay, in some way or another, either biologically or emotionally, or it's going to drain the money of the patient. Some way or another, it's going to harm our patient. So how to overcome it? It's very difficult, and leave out all these things. The first biggest challenge is to understand that or accept that we will make error in our decision. Okay, if we think we are always correct, then there is no point in discussing any of these things. Okay, no one can ever be correct. No one, not all the time. You all agree? Yeah. So the first challenge is accept that we all make error. Okay. And calculating from the error will what that's what will lead to a more analytical judgment, which in a later part of our life will become more intuitive. So these are some of the strategies you have to develop insight or awareness about our decisions. Okay, we need to be aware about of decisions why I have selected a particular course of treatment. Okay, is there a physiological rationale behind? That's why I selected this, or the evidence is saying that this is good for the patient. That's why I selected it, or because my institution has said me to do this. May be wrong. What your treatment may be wrong, but you have to be aware that why you have selected a particular course of treatment. And consider alternatives. Okay, sometimes we think this is the right or this is the correct answer. I just go in with it. It may be correct. Okay, but try to keep some alternatives. Could it be this? Yeah, just like our differential diagnosis. Okay, so consider alternatives for treatment. So if you think, okay, if manipulation is the treatment I think is better for this patient now, consider alternative. Okay, can exercise therapy be beneficial for this patient now, or doing nothing can be beneficial for him now? Okay, so consider alternatives, and once you consider alternative, you can go back to your original decision. That's fine. But most important thing is you need to consider alternatives because that will help you to reflect your decision or reflect your initial decision. And metacognition is just the same. You be aware of your decisions. That's the metacognition. And decrease reliance on memory because we know that we all have inclination towards most favorable outcome or most worst outcome. Okay. Say for example, you have seen நிறைய ஃபேஸ்புக்ல வருது வெப்சைட்ல இருக்கு பேஷண்ட்லாம் வந்து சொல்றாங்க என்ன சொல்றாங்க they give testimonies, right? If you want to brand your clinic or brand yourself as a physical therapist, what do? You put a video of the patient, okay? What it actually means, they have selected the particular patient, okay, for into. Yeah, and those are the patients which will remember for a long time. Yeah, but they may have attended few other patients in the similar time for similar condition who may not have improved. Yeah, but we rely our memory on the most favorable outcomes. Yeah, so say for example, if you have selected therapy for that patient, okay, from that point for that condition, what is your line of treatment? Therapy. For the same condition, the another therapist have selected manipulation as a line of treatment, and the patient improved. Now, for that therapist, what is the first line of treatment for the other patient with the same condition? Manipulation. Yeah. So we rely on our memory of what worked best for the patient based on our experience with the patient. So we remember the most best outcome from the patient. We forget other things. So try to avoid relying on our memory. Okay. So have some
Memory alone.
sir?
Memory alone.
Memory alone, exactly. Right? So you could have specific training, okay? Because medicine is not just understanding the biology, okay? It is also mathematics, okay, in terms of probability, because we work only based on probability. Okay, all our known interventions are tested for probability. Okay, nothing is 100%. Okay, so we also need to increase our skill on understanding some mathematics. Okay, you leave out the complex method, but we need to have some statistical knowledge on the probability. Okay, so those specific training will help us to avoid some error. And simulation, okay, you could have some simulation exercise based on biased thinking and de-biased thinking and see how it changes your patient thinking from there. Cognitive forcing strategies, so you have to consciously make a decision. So you try to force yourself to select something. Okay, say for example, all these times you are thinking taping is the best answer. Now you have found that taping is not helpful. So every time, next time you have the patient, now you force yourself to move away from your instinctive thought of doing the taping. And minimize time pressure. So you take some time to take decision making. And since we are not working in emergency room, okay, there are a lot of time with the patients, okay. So take some time to analyze what have we uh, decided whether it is appropriate for the patient. Accountability, be accountable for the decisions we have made, and feedback is like whenever we say, for example, if we take a decision, it's good for us to talk with the peer. Yeah, if I think this is the best treatment, I discuss with my colleague. I discuss with fellow physiotherapists. Now, this kind of discussion will enable the other person to give feedback for my decision. Yes or no? So you have to involve in a group decision when it comes to an important, not for every decision, but when it comes to important and critical decision, or when you're stuck somewhere, the patient is not showing any improvement, you don't know what else can be done. So you can involve the other persons in the decision making, and you can have shared decision making. You can even involve patient with the discussion, and you can come up with a solution. Yeah. So these are some of the ways with which we can try to avoid this cognitive error. Okay. This cognitive error is not always deliberate. Okay. So don't blame yourself, or we don't blame ourselves for this cognitive error, because we tend to make mistakes, because that is the survival instinct. Yeah. Because if you take the history, when you see a bush, okay, which is like காட்டுல ஆடுது, காட்டுல, what is the immediate intuition? What செடி ஆடுதுன்னு நினைக்கலாம்? ஆ? ஒரு காட்டுல செடி நல்லா ஆடுதுன்னா என்ன இருக்கும்னு நினைக்கிறீங்க? என்ன அனிமல் இருக்கும்னு நினைக்கிறீங்க? Lion. Yeah, we will not think deer. Yeah, we all think lion. ஏன்னா deer நினைச்சு அங்க சும்மா இருந்துட்டோம்னா இருந்தா செத்தோம். Yeah. So even though it is deer, we think it is lion. Yeah. So we are designed like that. Our instincts are calibrated for survival. So whenever we take a decision, it is our nature to take the decision like that. But we can override that by one strategy is you be aware of how you take a decision. So always try to reflect how you have taken the decision. Okay, that way I think we can overcome these errors, and we can be more systematic and more rational in our decisions. Okay, so I think I have made a point. So, you have any doubts? Sir, if you come and see me tomorrow, you will know why I am not, why I am not saying anything about it, because I mistake right and left. Yeah, not good. Then the physician surgeon comes and asks me why the patient is not given an incentive parameter. So I can just give you or tell you it's wrong. How to make it happen? It's
How you are handling your situation?
so there is no solution, or there is no universal solution for this.
Okay.
So what is that about? When is the door not to do? Like, I'm not asking for an exact answer, however you not say, but I'm just asking.
No, when we think it is something, okay, but it is not that. Okay, that so we try to make connection. Okay, even though there is no obvious picture of a dog, there are some dogs here and there which resembles like a dog. Immediately we made a pattern. Yeah. So even though there is not actually a dog, we try to perceive that as a dog. So we try to perceive even though it is not that exactly, but because of our beliefs and experience, we perceive in the way we want.
That is not about the door also.
Yes. When is the door is not a door, when it is left open. It's agile.
Okay. So, do you have any other patients as, for the full day today, so actually allow 15 minutes of Q&A and then to finish.